Welcome to First Star Let's Chat, an athletic therapy podcast. I'm your host, James Gardner, certified athletic therapist, certified strength and conditioning specialist, yoga instructor, human being. This platform, for the pros, by the pros, anybody in the performance space, and beyond. Welcome here to share in the stories of professionals, experiences, journeys, learning along the way. It's a platform to connect, to network, and to be a part of a community that cares, with conversations that matter, experiences that resonate, and generate ideas, thought-provoking, organic dialogue, passionate pros. Brought to you as always by First Star Therapy, Mobility Tape, Epic, and Benchmark Athletics, in association with the Canadian Athletic Therapists Association. It's First Star Let's Chat, an athletic therapy podcast. Thanks for being here. Thank you for being a part of it.
Welcome to First Star Let's Chat, an athletic therapy roundtable brought to you by First Star Therapy. I'm your host, James Gardner, and this is a platform for the pros, by the pros. Passionate pros, organic dialogue. Let's chat. Thanks for listening. Let's roll.
This is Let's Chat, an athletic therapy roundtable, session 19 already. Third in, 4 or 5 nights. Each one seems to be gaining momentum. Lots of people on, lots of people talking about it. Tonight's a big one, but before we get to introducing Dr. Zarnett and his bio, we'll just go through the ground rules. This is being recorded for all intents and purposes of saving the world one conversation at a time. And for those of you that wish to go back in time and archive and listen to this again and again and again for all of the points that we're going to be talking to or talking on, I will get the quiz up at the end of this with a gentle reminder from somebody, or not so gentle, if you so choose. If you have any questions, comments, concerns, etc., please use the chat box down to the right. If you're more comfortable, use your mic. Towards the end of this, we'll have a little bit of an open Q&A. Dr. Zarnett was just informed me he's also on call, so if he has to step away, that's obviously first and foremost. So if that happens, we'll do our best to continue on, and then he'll jump back on when he can. I think that's about it. Yeah, they'll be archived. I got Saturday nights is up and archived on YouTube. Adam's session on Sunday night will be archived, as well as this one by tomorrow. And then we are right back on track. And away we go. So let's chat, an athletic therapy roundtable. This is session 19. Appreciate you all being here this evening. And our guest this evening, another orthopedic surgeon who has served numerous roles and continues to. And we'll hear about all of those and the journey of this COVID time and returning and what that's going to look like, as well as, and maybe more importantly for most of the therapists in the room, is the therapist-surgeon continuum, how we work together, how we go back and forth with medical doctors, orthopedic surgeons, etc. So big insight, and I'll go through the bio here first and introduce Dr. Zarnett. Dr. Rick Zarnett is the medical director of the Centric Health Surgical of Toronto. He is a Royal College Board certified orthopedic surgeon with special interest in arthroscopic surgery of the knee and shoulder and reconstruction. He is also the division head of orthopedic surgery at Humber River Hospital and orthopedic consultant to the National Hockey League Player Association. He's previously been a member of the medical staff for the Toronto Maple Leafs hockey team and is currently the head physician for the Toronto Argonauts football team of the CFL, York University, and the St. Michael's Majors hockey team. Dr. Zarnett received his doctorate of medicine at the University of Toronto, followed by obtaining his master's in medical science. He completed the Galley Surgical Training Program from the University of Toronto and research fellow for the Hospital for Sick Children. He then completed an orthopedic fellowship in arthroscopy and sports medicine with Dr. Robert Jackson, followed by an orthopedic fellowship in arthroscopic surgery at the Toronto Hospital. Dr. Zarnett is our guest this evening. Dr. Zarnett and I know each other on the level of York University football, a few athletic banquets, a few phone calls outside of those things, and a really approachable guy. He's been on the sideline for a number of years before I was at York. After I left York, continues to have a very good relationship there. And Dr. Zarnett, really appreciate you taking the time out this evening to be the guest, our guest, and to inform us on so many levels. So appreciate you being here and taking the time out.
My pleasure. Glad to be here. I think that bio you read's a little bit dated, though.
All right. You can
Some
update it for me.
majors have not been around for probably 10 plus years, and so I don't do that. And I'm no longer the head of orthopedic surgery. I did that for about 12 years, and
Okay.
I did my time, and now somebody else has an opportunity. But otherwise, pretty good.
My due diligence, and on my travel back, I was like, I forgot to ask for a bio. I should be able to find a bio. So anyway, we did well enough. We got the major points in. I mean, you're a surgeon. You've been doing it for a long time. You have a lot of good relationships, a lot of insight, and currently with the Argos and York University, which I think is primarily how we know each other, and how most of the people on here would be familiar with you in terms of being in Ontario and with those organizations or organization as we go through. So first and foremost, COVID has been a crazy time, and one question that pops up on a regular basis is, are you watching Tiger King? So we'll start there, and have you watched that, or are you going to, or where are you on that one?
So yes, I have watched Tiger King, and in the first, I guess COVID shut me down around mid-March. So it's been a good probably 10 weeks. And people asked me what I was doing during COVID, and my standard answer was, got up in the morning, had a coffee, rode my bike either indoors or outdoors, had another coffee, then watched Netflix, and then I repeated that the next day. So that went on for about 2.5 months. So I think I have seen everything on Netflix.
All right. Well, Tiger King included. We have this sort of running tally, and I think that takes it to a 2-point lead again. It's not right because it's got to be 9. Anyway, 15, 13, something like this. This is where it's at because we had 9 guests on the weekend in a panel discussion. But I haven't watched it yet. The fact that you've watched it and that you drink coffee and then go for a bike ride, all good things. I can follow suit. I'd say we've done about the same things. I wake up, I have 3 coffees, and then I don't bike, and then I don't watch Netflix, but then I do repeat that the next day. So we're similar on that boat. You were saying that you just returned today. How has the time been being away for you? Obviously, your role encompasses a lot of things. So stepping away from that, how has it been? We had Dr. Desai on, just trying to compare and contrast. Have you been doing like clinics from home or just shut down completely? How has it been for you?
Yeah, so I've done a little bit of home telephone medicine. I usually do that, 2 or 3 mornings a week. And that's about it. I've been on call 3 or 4 times, but I haven't done any operating. And today was the first day I've been back in the hospital in 2 months. I had a fracture clinic this morning. It's the first clinic in a few months. But it's interesting because my wife's a family doctor. So she is in the same situation. So we've both been sort of home. I'm in my study. She uses the kitchen as her office, and she's phoning patients, I'm phoning patients. And then we sort of meet in the middle and drink some more coffee.
There you go. I mean, at least you have the home brew working for you, and regular kitchen usage is always key for coffee. But it's a really interesting time. And how did the clinic go this morning? Was it just like catch up time with a whole bunch of post-surgical patients, a mixture? How did that one run?
Yeah, no, I mean, I haven't operated in 2.5 months, so there was a few post-surgeries, but most of them we've dealt with over the phone. It was basically a few people who needed injections who have been waiting, and a bunch of people from Emerge. It's funny, in this COVID situation, most patients are quite reluctant to go to the hospital. They want to stay away from the hospital as much as they can. And you would think that the patients who come to the hospital with, orthopedic or musculoskeletal injuries would be, mainly fractures or acute injuries. So I did see a few fractures, saw somebody with a torn Achilles. But you still get these guys who come into Emerge, and it's unbelievable, who've had, shoulder pain or ankle pain for 2 or 3 years. They decide yesterday was the day they should show up to the hospital to be assessed in the emergency room. And, I work at Humber. Humber has the most COVID patients in the province, or we did last week. We have over 90 COVID patients in hospital. And you would just think that some of these guys whose back or shoulder or ankle have been sore for a year or two may want to stay away, but no, they just come in to see what we can do for them. So interesting.
Yeah, interesting take on it from a lot of different angles. We just drove up from Florida. I think I mentioned it to you yesterday when we chatted, but we drove up and it was almost like nothing was going on in some of the states that we drove through, and in the southern states. And then as we got a little bit further north, definitely like mandatory mask stuff and all the things that all the situated knowledge along the way, but interesting take along the way, very different. I'd imagine the hospitals are going to work in a little bit of a different fashion moving forward. Um, Being away for 2-3 months from surgery, that's not like, is it like a bicycle? I mean, you don't forget, you've been doing it for a long time, but like, I don't know. I feel like I need every now and then to tape an ankle or do something like that just to stay up on it. But how do you keep up with that stuff? Is it sort of just it's always there, or I don't know? You've been doing it for a long time, but how do you stay sort of fresh and ready to go?
I think you should check with me next week after my first OR day.
Well played. Yeah, I won't.
I don't think it'll be much of an issue. I've been doing it long enough, and I think it is like riding a bike at some point.
Yeah. I mean, you guys go through all the sterility and all these kinds of things before you start surgeries anyway. So on your end, not too different. But is your caseload going to sort of filter back in, or is it going to be a full caseload? How do things look at the hospital starting out for you?
Right. So the hospital starts out on a ramped up basis. So at Humber, we have about 25% of our regular OR time in June. So I normally have about 6 days a month at Humber. I have 2 days in June. So it's a start. I'll be able to do the same volume on a day-by-day basis, but there's a big backlog. A lot of patients were canceled, and the list is just getting bigger. So I think it's going to be really tough for anybody, not alone myself, just to catch up and get the backlog done and deal with the new patients. But you do what you have to do, and you can just do the best you can. What I've decided is, the hospital's asked us to prioritize patients, but we can do that any way we want. And I took the philosophy when we started canceling patients back in March that the first patients canceled would have the first opportunity to rebook. So I've been just going through my list, and if they're available and they want to go ahead, that's what I've been doing. The hospitals asked us, give us certain criteria. They want us to do fairly young and healthy patients. They prefer outpatient surgery rather than inpatient surgery. And so I do some total joints, but I'm just putting those off now because I'm trying to get some of my younger athletes who need surgery done. But interestingly, I booked my list for next Tuesday, and I had a couple of young females, like 16, 17-year-olds who were booked for ACLs. And the hospital won't let me book them because they have a policy right now. They don't want to do any pediatrics.
Huh.
Now, by any stretch of imagination, a 17-year-old woman who's going to university is not, in my opinion, a pediatric, but their definition is anybody under 18. So I couldn't do those patients, which is kind of strange, and you can argue as much as you want, but I don't think that makes much sense.
Yeah.
So interesting, but I guess hopefully in stage 2 of the ramp up, I'll be able to get them done, but they were nevertheless quite disappointed that they couldn't go ahead.
Right. Yeah. Strange times, strange rules. I guess we just kind of follow along and see how it filters back in slowly, and hopefully they're all right, or they find a good athletic therapist to carry them over until they get to you, and then a good one on the other side too. How did you get into orthopedics? Like, when did you figure this is for me? This is what I want to do. How did that come about for you in your career?
Yeah, I think I think from day one in medical school, that's sort of my goal was to be in orthopedics. And I think it was just really, I was very interested in sports. In high school, I participated in a lot of sports. I was one of those guys who did a lot of different sports, wasn't great at any of them. But in high school, I was on the swim team, I was on the football team, and the basketball team. And I just became interested, and I actually tore my ACL in my last year in high school playing basketball. Mm-hmm. So I think that sort of tweaked my interest, and I had surgery when I was an undergrad. I had actually in medical school. I went through undergrad with the torn ACL, with the knee buckling every once in a while, and then during medical school I had it fixed. So I think that sort of tweaked my interest, but I was sort of geared towards that right from day one. Now, it's interesting. I have a son who's now a 4th-year orthopedic resident. He'll be a 5th-year orthopedic resident in July at UBC.
Oh, wow.
So I got a son who's following in my footsteps, so a little bit of different clinical interest than me.
Okay, very cool, very cool. And the surgery in
Oh,
in
is James frozen there?
am I frozen? I might be. Am I still here?
Yeah, I got James frozen. Can anyone hear me?
Yeah, I can hear you, Rick.
Okay.
I can hear you. Am I still frozen?
There's the Argo. There he is. He's back.
Hey, I'm back. I don't know if I'm back or not. I don't know what happened. I'm in a country that's supposed to have good internet now, and this is the first time there's ever been a hiccup. So here we go.
Well, we were talking about you while you were gone.
Yeah, great. I'm sure it was all terrible, and that's perfect. Just leave it the way it should be. I heard the joke, not such a joke, about the social distancing in the crowd or in the standings, right? There's lots of distance between the top and the bottom. Only a joke, getting better. You were mentioning, I was going to make some bad joke about you doing your own surgery in undergrad, and that's where it started. But did the rehab and the surgery go fairly well on yourself, like for you in undergrad? And did that sort of enhance your want or your desire to continue down the orthopedic path?
Yeah, I think so. Yeah, the surgery went well, and it was tough rehab because those were the days when you had an ACL and you had a full leg cast on for 6 weeks, and the cast was so big they used to incorporate straps in the cast to hook over your shoulders to support it. So it was barbaric at the time when you think about it. And the cast comes off at 6 weeks and there's like really no leg left at all. So it's amazing, the difference now and then. But yeah, that certainly I think tweaked it and allowed me to sort of seek out some electives during medical school, which cemented the fact that that's really the way I wanted to go. So I really didn't have any other. It wasn't between anything. It was always orthopedics from day one.
Yeah, nice. And you talk about how things used to be and how they are now. We've had a lot of discussion about understanding the patient or athlete-centered model and how that's how that's most important to deliver in terms of rehab or outcome-based or even evidence-based. You need to understand who's in front of you and these kinds of things in order to do well with those things. In terms of the surgery, the major milestones along the way, you talk about strapping a cast up over your shoulder for an ACL to the point now. How long are your surgeries? Can you just give us, everybody who's on here may not be familiar, but a general overview of what your ACL surgical procedure sort of entails?
Yeah, so I'm primarily a bone, tendon, bone guy. I've been doing that for a long time, and there's been a real swing in momentum over. I've been in practice, close to 30 years. So when I started out in practice, bone, tendon, bone was considered the gold standard. And when you look in articles now in the literature, it's still considered the gold standard. But about 15 years ago, there was a swing towards hamstring repairs, but it's swinging back again now towards patellar tendon because of the long-term outcome studies, particularly in Scandinavia, where they have a great model where they can capture almost every surgery in the country. And then long-term studies in North America are showing the re-rupture rates are significantly less in a patellar tendon. So that's basically what I've been doing, and I never really swung away from it. I probably do about 10% allografts, which I think is a fantastic operation. The rehab is really easy, the morbidity is very low, and patients love the operation. You have to be a little selective on who I do them on because the allografts are quite expensive, and the hospital has to buy them. So they're about $3,000 or so. And as long as I sort of pick and choose who I do, the hospital doesn't get too excited. But if I sort of did it on the majority of patients, they would come down on me just because the budget couldn't support it. So I do a lot of allografts, but I'll use them for revisions, and I'll use them for athletes who are, rough guidelines, females over 45, males over 50, just because they rehab so easy.
Right.
If I did my ACL done now,
Mm-hmm.
that's what I would have done for sure. So it's a really, really easy rehab. Doesn't shorten the time back to sports, but it makes the effect on their lifestyle or the impact on lifestyle is really quite negligible after an allograft ACL.
Yeah. Yeah, really cool innovations that have come through surgery and all these things over time. For those of you that are fairly new to the exposure to surgery or haven't had a lot of exposure to surgery, it's always good to bone up on that stuff. And that was a good joke, but always good to catch up on the reading and what repairs are being done with your athletes. If you have access to the surgeon to talk about it prior to, or at least the protocol as to what is going to be done, and then the protocol afterwards if the surgeon has one assigned. Rick, you've had a really long-standing relationship with York. When I think Cindy was probably the originator with that. Is that where it started, with Cindy Hughes and yourself?
Yeah, that's right. I met Cindy when she was at she wasn't, it wasn't, where did she start at?
She started, I can't even remember that one.
No, not Sheridan.
Humber.
Humber, exactly.
Yeah.
Started Humber. And so we had sort of met through some patients, and then she got the job at York. And that's when she decided she wanted to build a sports medicine team and asked me to come on. And that, I'm guessing that must have been around 95, maybe, a rough guess. So I've had a relationship with York since 95. I've even been to a couple of their playoff games, which most people won't remember.
Well done. Yeah, that not too many people do remember those, but the Red and Blue Bowl is always a hot topic in Toronto. You know, that's the new championship. That's the new playoffs for now, until things continue to evolve, hopefully, for both programs, so we can get them back up in the top end of the standings. But yeah, so a long-standing relationship with starting with Cindy and a conversation, and that kind of evolved over time. This is where when I came back to York, I got to know you a little bit. Britt obviously knows you quite well, worked in your office with you as well through her journey and with the Argos. And I guess if we can kind of talk about how that relationship works on your side, and then on our side as therapists, you know, we have, there was really good and is a really good relationship with you in York, where they can pick up the phone, call you if something goes, you know, not so well during a game or not so well during a rehab, and they have a little bit of access to you, which isn't standard across the board unless you're at, you know, really high level sport, or somebody like yourself who makes yourself available. How does those, we talked a little bit yesterday about some good relationships and not so good relationships with ATs. What makes the not so good ones? I guess let's start there, and then we'll work out.
So now you put me on the spot. So I've had two that I really don't like to think about. So one was when I worked for one of the junior hockey teams, the athletic therapist who was the team therapist and I sort of butted heads a bit. He lacked a lot of self-confidence, and so he used to be, he would ask for a lot of different opinions, and he would go outside the team because he was never sure. And yeah, so that wasn't the best. That was a short-lived one for a year or two. And then I did have a relationship with one of the professional teams with the athletic therapist. It wasn't the best. And it's, you know, it's sort of public knowledge. So it ended up, we sort of butted heads, and he prevailed, and I was replaced. And then 2 years later, they got rid of him, and the general manager came back and asked me to come back to the team with my team. So it was a little tough at the time, but it all worked out in the end.
Yeah. So a couple of tough ones, and some things that don't really work in certain scenarios, personalities, or just, yeah, those are great examples for everybody to sort of learn from and hear. But good relationships go a long way. At York, it's sort of a bulletproof system in terms of getting athletes to see you if and when an evaluation is needed, and then imaging, etc. And then if surgery is necessitated, then the rehab just kind of trickles down, and it's almost like the rehab protocols are already in place. They've been modified and tweaked as the years go on, depending on who's involved, or what sports or what strength and conditioning specialists are there. But always really good to pick up the phone, check in with you as to, you know, what the tissue looked like on your end. How did it look compared to what you found in the orthopedic room? How would you suggest athletic therapists sort of address surgeons in terms of good questions to ask, or things to ask in terms of rehab that aren't, you know, overstepping, but are educated and just from being informed, I guess, is kind of the angle that I'm looking for.
Yeah, so I'm a sort of the adage that there's no bad questions, they're all good questions. One of the things that's changed in time that disappoints me a bit is that in the past, especially with York, when one of the athletes was injured and they came to the surgery, we could bring in the athletic therapist to watch the operation, or an athletic therapy student. That was a great learning aid for the therapist, for the students, and it was great for me. But unfortunately, because of privacy issues now, the hospital doesn't allow that. So that's unfortunate, but that was a really a great opportunity for the therapy students. And I think one thing probably that a lot of people don't know is that my administrative assistant has been with me for 8 or 10 years as an athletic therapist by trade. So Marianne's really good, and she's very good at screening this stuff because she worked in the field for so long. So when a therapist from the school or one of the schools or one of the PTs calls up, they're talking to someone who's well educated, and Marianne can really screen them well, and she knows, who needs to be seen, who doesn't need to be seen, and she's been a tremendous help for me for years. And Britt was great. Britt filled in for a few months when Marianne was off on mat leave, and Britt did a fantastic job. I was sorry to see her go, but she had a great opportunity at York, which I think's worked out well for her. I'm sure she's happy with that.
Yeah, and those are, I think the question popped up as well in terms of having athletic therapy students or athletic therapists in the OR. I think when I was in school, I was able to get in for one of your surgeries with somebody else, and that was, really good opportunity. YouTube's such a good thing now that you can sort of find some clips, but not really the same thing. And when it's your athlete, it really helps in terms of some empathy and really getting to know what's going on and understanding why things are in certain places or why bruising is happening, or, these kinds of things that you don't necessarily gain from the textbook. Great question, Jill. And it would be a great opportunity if we could have that come back around again, but who knows? Don't think that's going to happen.
Well, I'm not sure if it's a hospital-based thing, but our hospital just there, they've cut down with all the privacy issues. It's difficult now.
Yeah. And then you bring up another point. I spent some time in pro sports in the US where very much like ATCs are respected as almost physician assistants, where orthopedic doctors will send over ATCs to do evaluations if they're in surgery, and they'll take their word for it and these kinds of things. And you have your assistant, and you brought Britt on, and all these, as an AT friendly surgeon, your relationships with ATs and sort of your acknowledgement of what ATs can do is massive. Have you found that that's pretty consistent, or you're sort of I guess in the pro sport world it is in Canada with hockey, but and the CFL would use ATs as well, but is that pretty common or not so much in terms of other surgeons that you connect with on a regular basis?
Yeah, I throw that back at you guys. I don't know. I'm interested what the people on this Zoom call, what their experience is with surgeons and how open the surgeons are with them. I only know my relationship and, the doctors I work with closely, like Dr. Clarfield and Dr. Deacon, who have the same sort of attitude I do. And that's probably, first of all, why we get along so well and work together, because we have the same sort of philosophy, but I'm not really sure what the philosophy is in the community with other surgeons. So I'd be interested if any of the people on this call could sort of pipe in and tell me what they think.
Yeah. So if anybody has experience with that, has attempted and it hasn't worked, has attempted it has worked, has a good relationship, doesn't have a good relationship, feel free to type that in, or you can unmute and we can sort of open this thing up a little bit. This is the purpose of these chats. I was mentioning to you yesterday, and I try to do my best to sort of create awareness within our profession, within Canada especially, and then a little bit beyond as well, as we continue to grow and sort of gain a little bit of acknowledgement. It's about awareness. It's about acknowledging the breadth and the scope of practice that we can bring to the forefront. And I've always valued our relationship with you through York, and my own relationship with you sitting next to you making bad jokes at athletic therapy banquets or whatever it might have been. But having access to a surgeon and having the ability to sort of ask some other questions that may not be accessible most of the time goes a long way. And in the rehab, definitely we can check in with Dr. Zarnett on a regular basis. Well, the York therapy staff will check in and say, we're ready to push, or we're ready to slow this thing down a little bit. Can we check in? There's also a lot of trust that you've built up with the relationships at York, the therapists at York too, right? In terms of you get done with the surgery and you hand it off, and do you worry about that stuff, or the surgery goes well, you're pretty much like, they can't mess it up too bad, it'll be okay.
No, I don't worry too much. I mean, as long as they're in skilled hands, I always worry about when the patient goes to a therapist, whether it's an AT or a PT that I'm not familiar with. And, when I see a patient who's having a slow recovery, range of motion, stiffness, pain, I think most surgeons say, well, the patient isn't motivated or they're not doing well. And, in my experience, it's not the patient, it's the therapist. And I can tell when I usually see for example, I do a lot of ACL surgeries, you mostly know. And I see them back at the 2-week mark, and I can tell if they haven't been to one of the therapists who I use fairly regularly.
Yeah.
A stiff knee is something we don't like. It doesn't happen very often, but it's almost always, I find, therapists who are just not aggressive enough or doesn't have enough experience, and they're basically shy and they don't want to push that patient enough. So the patients sort of like that. I don't blame them. I blame their therapist.
Yeah.
But, you've been in the business a long time, and what you do is you sort of find your go-to people. And Toronto's a big city, and I always tell patients, you have the same 10 or 20 different lines you pull out of your head for every day you're saying them over and over again. And one of the lines I say to everybody is that it's important to have a good surgeon, but it's just important to have a good therapist. And it's so true. You can have a good surgeon. If you don't have a good therapist, you don't have a good result, and vice versa. You have a good therapist, if it's not good surgery, you won't have a good result. So it really is a team approach in that sense, that you need quality people on both ends.
Yeah, I think that's huge. That's huge to hear, and it's huge to acknowledge on our end and on the medical side, the surgery side too. You talked about some ACL patients, and you talked about knowing when to push or when to hold back, and your timelines. There's a lot of stuff out there now with that's been made sort of public with some different practitioners in terms of when you need to get to certain checkpoints along the way with rehab. Dr. Desai actually touched on it too, in terms of you can't really do too much damage after that 6-week mark, but he talked a lot about trying to get range of motion back at the end a whole lot tougher than at the beginning. And so pushing range early and strength late, it makes sense in terms of a timeline for most surgeries. That's a pretty standard line. Would you agree with that?
Well, I think that for knees, for sure. I want to get range right away. Yeah. Because once you have the range, and it's just a matter of months. ACL return to sports usually 6 to 9 months, closer to 9. So if you get your range back in 4 weeks, you have 7 or 8 months to work on strengthening. There's no hurry. If you're having trouble getting the range back, that's where the patients struggle. Right. But if they get the range back early, then it's really just a matter of going to the gym, being diligent, and working on strengthening. And even if they get strong, they're waiting for graft maturation, and you can't speed that up. As I tell the patients, nature limits you as well. Even a pro athlete, they can be rehabbing, 6-8 hours a day, 7 days a week. They're not getting back any quicker than the guy who's playing beer league hockey, because they can't speed the nature part up.
Right.
So I agree with Dr. Desai. Get the range, then the strength will come, and that's the easy part.
Yeah, and you invert that relationship, and it becomes a whole lot tougher. We struggle with a few patients at the back end trying to get 5 or 7 degrees of range at the end. It's really tough once you're dealing with a little bit of extra stiffness and these kinds of things. So
the one surgery though that I'm a little bit I back off a bit is when I do an arthroscopic shoulder stabilization.
Yeah.
So that'll limit their external rotation for about 6 weeks to about 30 degrees, and that's. The other line I pull out of the brain is I tell them it's like the tortoise and the hare. The knee is the hare. You want to get going. The shoulder, it's slow and steady. You don't want to pull the range back too quickly because you're worried about stretching out things you've tightened up. So that's the one exception that I'm a little bit slower and a little more cautious on range for the stabilizations.
Yeah, and when we go into the shoulder and we talk about the stabilization you're still using internal fixation with the sling when they're done. Is that standard for you? In the sling when they come out, you're keeping them in internal rotation? Are you keeping?
No, when they come out of the sling, I let them go into external rotation. I just limit them to about 30 degrees for the first 6 weeks.
Right. Okay. Yeah. So this is one where we're talking about a difference in joint, a different in technique, and obviously it would come down to the actual procedure. But yeah, limiting range for a mobile joint makes a ton of sense early on coming out of the gate, and not pushing that too much with the shoulder. I was talking about the flight back the other night, and I flew in the cockpit of the airplane unintentionally because there wasn't enough room in the plane because there was an 8-seater that the luggage was more important than me. So I sat in the cockpit and I had absolutely no idea what was going on. And the analogy, I guess, to this is very much like I try to educate, we try as a group of professionals as ATs to educate patients on what the surgery is going to involve and what the rehab is going to look like, as opposed to jumping in the cockpit and hoping everything's okay. How much have you done with therapists in terms of planning protocols, or do you pretty much just allow the therapist to follow a standard and then they can add and tweak as the time goes on towards from a strengthening standpoint or range standpoint?
Yeah, no, so I've had protocols that are fairly, written down and fairly rigid, but they were designed by myself and therapists. And then over the years, therapists who I've worked with closely, whether at the hospital or at the office, have taken the protocol, and a lot of them will say, "Can I put my own little swing on it? Can I update it or change it?" And so they'll work through it. And so, for example, the ACL protocol I have has been modified over the years by a therapist who gets interested and wants to upgrade it and change it a bit. And I'm certainly very happy for them to do that. I think it's terrific. So they're designed by both of us, but I would actually say the therapists are probably more influential on the protocol now because they're the ones who like to keep it updated and new.
Yeah, great. From a statistical standpoint, do you really basic statistical standpoint? How many surgeries would you do in a non-COVID year? ACLs and or shoulders or both?
Yeah, that's a good question. So I probably do about 150 to 200 ACLs. And then I'm just guessing, I probably do about 300 scopes.
Yeah.
And then, maybe 100 shoulders.
Yeah. Okay. I'll renege my earlier question of if you needed to practice during this time. Yeah. Obviously. So it comes down to this as well for therapists that are out there is understanding who the surgeon is that's doing the surgery as well, what the background is and how long they've been doing it. I found sometimes therapists or trainers or strength and conditioning personnel will actually try to go above surgical procedure and say, well, you don't want to go to this surgeon. They only do bone, tendon, bone, but they lack the information as to why bone, tendon, bone is still a very good option and if not the better option overall. Have you ever found that that's a thing that you have to, I don't know, I'd imagine you don't have to will people into it, but you ever have to have that discussion as to, why you think, yeah.
Yeah, because, patients will come in and they have a friend who had this or that and they want this or that. And what I usually tell them is I said, if the surgery, for example, like let's compare an ACL hamstring versus a bone tendon bone. They're both good operations. They both give you really good knees. It's really goes down to surgeon preference. And what I tell the patients, again, those other, one of those 20 lines I pull out every day is that don't pick your graft, pick your surgeon.
Right.
Because, if it's done well, you'll get a good knee either way. If you trust your surgeon, trust him to put what he thinks is best for you. Now you can see 10 different surgeons. You might get, 5 surgeons who think A is better than B, but the differences are pretty subtle, and it comes down to what the surgeon's what his preferences are. And I don't think the patients will have much long-term difficulty with either of them as long as they're done well.
Yeah, it's great insight and a great line that I think I'll go back and pull out and maybe we'll make a T-shirt or something. That's a pretty good.
Sounds good.
Yeah, don't pick your graft, pick your surgeon. And I think that comes down to sort of the analogy that we've been talking on here with different practitioners, surgeons, medical doctors, trainers, strength and conditioning people is the art form, the art side of things on top of the science, the quality of the work that you're providing or the quality of the patient care that you're providing goes a long way. I know that's a thing, and it's tough because you see a lot of patients in your clinic, right? Like you're seeing upwards of how many people on a regular clinic would you see at the hospital if this is, again, non-COVID, but in a regular?
Yeah, the hospital is a little different because a lot of those are fracture and fracture follow-up and surgical follow-ups. But, non-COVID, we'll probably see 40 patients in the morning there. But those aren't new patients, and a lot of them are pretty quick. They may be coming in just for an x-ray follow-up or sutures out. But in the office, we usually see, 4 to 6 patients an hour, which is a combination of follow-ups, new patients. So
Yeah.
it's pretty busy. But, with the COVID situation, it's all different now, I was in the office the first time this week, and I'm booking one patient, whether it's new or old, every 15 minutes. No patients in the waiting room. You have to call them up from their car.
Huh.
And so it's different. It's a nice, slow pace, but it certainly is different. And maybe that's going to be the new norm, I think.
Yeah.
For the time being.
Yeah. Well, I mean, just adjust to the new normal. I guess we all got to make some changes. I was just talking to somebody about going out. They were going out golfing. I'm not paying $1 million or going to jail for 3 years of my life. They were talking about golfing and how there's no, you got to wait in your car to be called up to get off on the tee box and all kinds of things. There's no beer cart, but if there is a beer cart or a nutrition cart coming around, you have to use card. You can't use cash. And yeah, a lot of strange adjustments coming around. I just want to jump back just for some of the therapists in the room that might not be familiar and to refamiliarize for myself as well. In terms of surgical consideration, a fresh injury that just happened, let's say Sunday, what are your rationale for jumping into surgery? What do you need to clear before you're going to go put somebody under for surgery for an ACL, let's say?
Yeah, so ACL, they have to have full range of motion. That's really my criteria.
Yeah.
So the swelling will come down as they get mobility. But if they have full mobility in 2 weeks, I would happily do it then. If it takes 4 to 6 weeks, I'll wait. If they start out with a stiff knee, they're going to have a stiff knee post-op, and they're going to be unhappy. And if they're unhappy, the therapist is going to be unhappy, and so is the surgeon. So even if it means waiting a little bit longer, I think it's fine. You're talking about a 9-month rehab really to get back to play, twisting, pivoting, or contact sports. 9 months isn't a firm date. It's 9 months, as the kids would say, ish. And
Right.
so 2 or 3 weeks on either end of it is not going to make a big difference. The reason you want to get it going earlier is just to move on with it, but certainly being conservative when you get the mobility back is the key. So I'll get them into therapy right away, anti-inflammatories, ice, get really aggressive with the mobility. And once they have the range of motion, then they're good to go anytime. Yeah,
great insight. I think these are talking points for most therapists to understand why there are sometimes delays that are necessary, even though the athlete wants to get going really early on as well. And for the shoulder, it's the same, or what do you advise when it comes to like a bank card or something standard when it comes to a slap repair or something in the shoulder that's fairly fresh?
Well, generally, usually they're more acute, chronic injuries you're offering on, not acute. There is some argument, and I will do a contact athlete who was a young person who was an acute bank card. In the States, it's quite popular. Here, one of the issues is we just don't get those patients that early. But if I happen to see one of the York athletes and they've had a primary dislocation, first dislocation, it's an interesting discussion because we know the incidence of recurrence in a young patient under 18 or under 20 is quite high. Mm-hmm. And so a lot of the decision is between the patient, the doctor, and the family. It really depends where they are in the season. So if they're early in the season, then usually a rehab let them play. The worst scenario is they have further episodes of instability and they get operated on. They'll end up with the same long-term result. But if it's towards the end of season where they're not really going to play again, or they have maybe a couple of games left in their season, you make a good argument for fixing them acutely because they're not going to be playing either with or without surgery till next season, and you can reduce the rate of recurrence from anywhere from 70 to 80% down to 10% or less. So if I have a varsity football player, for example, who has a primary shoulder dislocation last game or two of the season, I probably would say fix it, rehab over the winter, and then we'll know next year the chance of hurting is very low. If not, they have a pretty high chance of having further problems and not playing that season. So it's a good discussion you have to have with them, their family, and certainly everybody has to be involved in that. But you can make a good argument to do those ones acutely.
Yep. Awesome. Great. And in terms of the pro sport side or the high end athletic side, you talk about 9 months and you talk about not rushing nature in terms of graft maturation and these kinds of things. We hear about it. We see it on ESPN. We experience it in some of the athletes that we deal with. They want to jump the gun. They want to be playing football at 6 months because that's where they're at and they think they're ready. How do you enter those discussions on, I mean, you have the medical background, obviously, but from a therapy standpoint or a team-based approach to recovery, what's your advice in terms of having those conversations to potentially slow an athlete down or just like give them the reality that this isn't quite ready yet?
Yeah, that's a tough one. So I have a few criteria for to get back to sports, whether it's pro or amateur. And one is for, we're talking about ACL, so they have to have no pain, no swelling, full mobility, obviously. And then I do isokinetic testing on them. I want to make sure that they have good strength. So my threshold is they have to have at least 80% strength in the operative leg versus a non-operative leg. And then the other issue comes into, graft maturity. So, I used to let them all go back at 6 months. I've been a little more cautious, not for any reason, just because that seems to be the trend in the community. But at 6 months, it depends what the sport is. I will often let them get back at least into full participation in practice. And it depends. Some sports are a little less risky than others. I always get nervous about the rugby players because they can't brace. Soccer players often can't brace. They make me a little nervous, especially the females. Football, a little less nervous about because they can wear a brace. And hockey, I think hockey can get them back a bit earlier too because hockey, you're typically skating with a flex knee. You can put a brace under the equipment. And so it depends, on the athlete, the sport, a lot of variables, right?
Yeah.
You often get into a problem where you get these, young athletes, for example, hockey players who are, do something to the knee late in the season, January, February, and they need it fixed so they can go for tryouts in June and July. And, sometimes you just can't do that, but that's always one of the tough ones. I think one thing that your athletic therapists need to think about too now is that, the wait lists are going to be horrendous in Canada, Ontario in the next year or two, because we have this whole backlog of patients that we couldn't operate on. And as we ramp up, we still don't have the same amount of operative time that we had before. And so the patients are being quite anxious that they can't get their surgery as quick as they want to. So I think it's important that you reassure them that as long as they're not participating and doing anything that's going to further damage their knee, that there are certain operations we do, and ACL is one, rotator cuff or Bankart. They're not generally time-dependent operations. There's no period where if you wait, you're going to compromise your end result. There are things that are time-dependent. For example, an Achilles tendon rupture, a biceps rupture, a pec major rupture. There you have a window of opportunity. But the other ones, there is no window. And so as long as they're patient, they realize, that it's beyond their control, the surgeon's control, what they can do to get them into the OR, that long-term, they will have a good result, although the reason to do it sooner than later is just so they can move on with life. But it's really important, I think, to let them know that waiting doesn't compromise their end result. They still have a good knee, although it may take a little bit longer just because of the situation we're in and nothing you can do about that.
Yeah. Great advice for therapists and practitioners out there in terms of, there is a backlog. So if you're not comfortable with, preoperative care and postoperative care, you can do a lot of reading about what postoperative looks like. And in the meantime, really help out what preoperative care looks like or getting them prepped for surgery if and when that is going to happen. So this is great insight as well. We're pushing close to an hour. So if anybody has any questions for Dr. Zarnett that you'd like him to answer or address, Okay, here we go. Opinion or criteria for athletes returning to sport without a brace, or do you always suggest with a brace whenever possible for a certain time period?
Yeah, if possible, I do recommend a brace for the first year back. I think that's for a lot of reasons. One is they're coming off an injury; they are still a little weak. Proprioception hasn't been completely reestablished yet. So if they can wear a brace, I do recommend it. But as you know, we just talked about, the three sports you typically can't wear a brace in is rugby, martial arts, and soccer. Depends. Soccer is sometimes league dependent, often referee dependent. One league, the OUA, it depends which referee you get. Some will allow it, some won't. So if they can't wear it, it's not really a discussion. If they can, I think it's a good discussion to have with them, and it's highly recommended.
Yeah. Great question, great response, informed obviously on all angles. So that makes sense from this side. Sometimes athletes don't like the look, or they really like the look. It's not relevant to that discussion, although the tiger stripes are kind of cool on occasion. Anybody else with anything for Dr. Zarnett? We're going to jump down this whole path. I think the opportunity to dialogue with a surgeon, you're held to a very high standard when you're an orthopedic surgeon in our eyes as therapists, and as you should be. Would you have any advice in terms of like approaching somebody like yourself as a therapist? I mean, you have the relationships already, but if I was to try and get on board, because I have a bunch of athletes, I work with a bunch of athletes, would you have any advice in terms of how to address a physician in any realm to sort of bring them on board or bring them up to speed in terms of trying to align a network?
Yeah, I think personal introduction is always good. Putting a face to a name is good. And I truly believe that, good quality work will get you the referrals. There's a few people I refer to in different parts of the city, and I know they provide great therapy, and I've been sending the patient for years, and I've never met them.
Yeah.
So the reason is they've treated some of my patients. Patients have given me great feedback. The patients have great results, and they're my go-to people now in certain areas. And interesting. I've never met them, I've never actually really talked to them, but we just have this relationship where I know that they'll get good care, and they know if they send me their patients, they'll get good care, and it works both ways. So
yeah,
all I can say is provide good care,
yeah,
and the work will come. Build it, and they will come.
That's it. That's it. A great field of dreams analogy. Yeah. And it's great advice, networking and putting a face and having a professional relationship, or at least a professional outreach. It goes a long way. It's been a kind of a running theme with everybody who's been on here too. It's sometimes, it's always important to be able to refer outward, and then to have a good network. If you need something or they need something from you, you have this reciprocal relationship on both sides, which is fantastic when it comes to an athlete-centered approach. A question just came in. Your opinion on returning to sport without undergoing surgery for an ACL tear. If you want to speak on that one.
Yeah, so I think if they're playing organized sports, whether it's high school, university, or pro or semi-pro, I wouldn't clear them. They'd fail the physical. If it's a weekend athlete, you can't force them to have surgery. But if it's a guy who, plays a little bit of hockey on the weekends with his buddies or skis, and as long as they understand the risks associated with non-operative treatment, that's fine. I think they go ahead. But if we're doing preseason physicals on any of the York athletes, they wouldn't pass the physical, and they wouldn't be allowed. I wouldn't allow them to play.
Right. I once went to a lecture where a guy was talking about, I think he was talking about powerlifting, and he had no ACL in one of his knees, and he's like, see, you don't need an ACL. All these talk about surgery. He jumped from the floor up onto the desk, and I was like, all you're doing is moving in one plane of motion. Your ACL is very much not. Anyway, it was an interesting take on why you don't need ACL surgery, but he's since had ACL surgery. So anyway, because he was no longer jumping up on desks, I guess, or it was jumping down that was probably problematic afterwards. So great stuff, great insight, Dr. Zarnett. I really appreciate you taking the time with these questions as well, and just for being here this evening. It's always awesome to have a conversation with you, bad jokes or otherwise on my end. And the distancing thing goes a long way to have access to somebody like you for and beyond. So well, let's give it like maybe 2 or 3 more minutes if anybody has anything for Dr. Zarnett. ACL, shoulder, he's done it all. We can get those to him. Otherwise, I was telling the story the other night as well about a total reverse shoulder on an older patient. You didn't do it, I don't think. I think he went to, I'm trying to remember who he went to. It might have been Tim. I can't remember who it was. Anyway, and what an interesting rehab that was. That was something I'd never seen before. I had to do a lot of reading and a lot of try and throw out what the rotator cuff is supposed to do, and then let's figure out how the deltoid's going to do all that stuff afterwards. And an interesting rehab. But any interesting cases for you that you didn't anticipate, maybe like you did in the MRI and then you get in there and you look at the tissue, shoulder or knee, and it just kind of like it's much different than what you had anticipated? Does that happen on a semi-regular basis or very rare?
Yeah, not very often. And in fact, I can't think of anything right now. I'm sure there are some, but nothing that comes to mind recently. But as you get older, your memory's not as good, and so short-term memory is.
That's it. It's like those relationships with the bad relationships with those ATs. I had to stir the pot to try and bring those out in you. So we won't go down the path of the bad tissue you didn't know.
There's so many good ones, though. That's
overriding factor. Yeah.
Exactly. Yeah.
Fantastic. All right. So I don't see any other questions coming in here.
Would I be able just to ask a question? Can people actually hear me?
Yes.
Okay. So before this whole COVID thing, I was volunteering at Etobicoke General in the fracture and wound clinic. So I had 2 orthopedic surgeons, about 6 nurses, a couple of ortho techs that would pull up the x-rays and stuff with the surgeons. And looking at how the orthopedics surgeons go about their schedule, seeing patients every literally 5 minutes. I talked to some of them, and not that they're not rude whatsoever. Just it almost seems like because they're so busy, they don't have time to explain what they're doing or answer questions. So I mostly work with the ortho techs, sometimes in the casting room, and they teach me how to cast. They teach me what they're doing and how to move the bones depending on what fracture they had in order to mold the cast. So I guess my question for you would be how would you go, or what would your advice be on me or any of the volunteers or therapists that want to work with a surgeon? How would you go about asking you and trying to learn from the surgeons without being overbearing on their already busy schedule?
Right. Yeah, that's a good question. So the fracture clinic is really a lot different than the offices. So the fracture clinic is based on volume, and there's really not a lot of time because there's so many patients there. So I think really the best thing is if you have a relationship with one of the surgeons, you can come to the office one day. Because the office is a much slower pace. A lot of the new consults come in there. They can spend a lot more time with the patient and with you. But in the fracture clinic, you're under the gun. It's just rush, rush, rush. And patients will complain too. I'll see a patient. I'm sure patients of mine go elsewhere and they'll say, yeah, I saw the doctor in the fracture clinic. He spent 5 minutes or 2 minutes with me and I really didn't get any time. That's what fracture clinics are all about, unfortunately. So I think the better opportunity is a one-on-one where there's not a lot of hustle bustle. There's less patients. The flow is a little quieter, and you can spend a little extra time with the surgeon and the patient to get a better feel of the situation.
Yeah, great advice. And fracture clinics are tough, right? And it comes back to, for me, some of our athletes have been to see you in those, and they come back oh, he only took 2 minutes. I'm he only needs 2 minutes. Listen, he's done this for a long time. You're going to get a lot more discussion with him in the future and these kinds of things. And when it comes down to it, I'd much rather have a little bit extra time on the surgical table than in the fracture clinic anyway. So, yeah.
What I do though is, I'm just as guilty. I do see patients in the fracture clinic, although not a lot of the surgeons spend more time in the clinic than I do. I only spend about half a day, and there are surgeons in my hospital spend 3 half days.
Yeah.
So if I see anybody first off, if I see them in my office or if I see them in the clinic and I've diagnosed them as they're a surgical patient and they need surgery, I realize I haven't spent much time with them and they haven't had a lot of chance to think about questions. So without exception, any surgical patient I see back in my office again prior to surgery. So they can book surgery, and then they come in about 1 to 2 weeks prior to the operation. That way, number one is I get to re-examine them again in case those things do change. They get to have thought about questions they can ask me, and I can go over all the pertinent surgical things when they're going to start the rehab. We're going to do the rehab, and there I have a lot more time. So those patients who get 2 minutes in the fracture clinic are going to get 15 minutes in the office at some point prior to surgery.
Yeah, it's great. I think it's perspective, and it's understanding the realities of fracture clinic versus clinic, inpatient versus outpatient, pre-surgical, post-surgical. All these things matter when it comes to time, and obviously time is limited when you're one of the best surgeons and you have a whole bunch of people coming in to see you for different reasons on different days. So really, really insightful to understand, the flow of things and how things have been affected, as well as building relationships with ATs and keeping this thing moving. So I don't see anything else coming in here, and it's just about an hour. I'll cut you free, and that's another good pun on cutting. But I really appreciate your time, Dr. Zarnett, this evening. It's been great. I look forward to seeing you not on your surgical table, but in the future here, the near future, now that we're back in the city. And for all that you do for all the athletes out there. You don't get thank yous enough, but we thank you on their behalf, and for being so accessible for us as therapists. It goes a long way for us in terms of building our credibility and our understanding. And so really appreciate you taking the time out. Thank you so much.
My pleasure. Good catching up with you, James, and hope maybe we can do this again another time.
Yeah, that'd be great. And maybe under different.
Take care, everybody. Nice talking with everybody, and good luck and stay safe.
I appreciate it. Thank you.
Okay.
And for everybody else who's attending, thank you very much. This has been Let's Chat, session 19, an athletic therapy roundtable. I will hit stop, and I'll hang out for a couple minutes here. Sunday will be, I'm just trying to get ahead of myself here. Sunday is York University Sport Performance Team. So it's Emerson Morisuti and Sam Isles. They'll be on as a tag team, a duo, talking about performance from that end within the varsity setting. And the varsity setting, AT, S&C performance type model from their end. So that'll be a good one. Next week is the 10th, which is an MLB. There'll be a current MLB athlete on Wednesday, and then a Wrestling Canada athlete on next Sunday. So a few big ones coming up. Just keep this thing moving, keep dialoguing, keep talking. Really appreciate you guys all being here tonight and beyond and before. I'll get the quiz out here. You're still here, so maybe some of you are waiting for the quiz. Let me see if I can find it. I'll pull it up. But while I do that, I'll stop the recording as of now. I think. Thanks again for being here. Thanks for listening. Thanks for being a part of this community. Check us out online, firststartherapy.com. That's FIRSTAR therapy.com. Or email us with feedback, consult@firststartherapy.com. CONSULT@firststartherapy.com. On Instagram @firststar.therapy, and our podcast host @letschat.at. This is First Star Let's Chat, an athletic therapy podcast.